Good morning, everyone. It's so nice to see all the names and the countries in the chat. So please go ahead and introduce yourself. Really nice to see so many different nationalities. Welcome to this, the first chronic cough patient conference. Chronic cough is a community that we are really interested in building, and therefore we are very excited to introduce this, the first chronic cough patient conference to you today. My name is Kjell Hansen, and I'm the chair of the European Lung Foundation. Because we have such an international community with us today, we would like to start by drawing your attention to the translation tool that we have available for simultaneous translation. You may find the link in the chat box, and this will take you to the site where you can choose your language and be able to read the automatic translation alongside the conference page. So this is only the second time that we have used this tool, and it's a trial. So we hope that it will be useful, but we understand that it's not perfect yet. We would like your feedback on it also in the end. We also have one presentation for you in German, so we'll let you know how to access it. ELF is a patient-led organization with a patient-driven agenda that works internationally to bring patients and the public together with healthcare professionals to improve lung health and advance diagnosis, treatment, and care. ELF works in partnership with the European Respiratory Society to develop the union between lung health professionals and patients, and we have more than 20 years experience in doing so. We are, amongst other, working together with the EIS on what we call clinical research collaboration, and you might read more about that on our website. This patient conference is conceived as a collaboration between ELF Patient Advisory Group in chronic cough and the clinical research collaboration Neurocough, New Understanding in the Treatment of Cough. Neurocough Project is a pan-European project that brings both clinicians, academic researchers, and the industry together with a view to improve care and treatment for patients with cough. And the ELF Cough Advisory Group, they bring a lot of different experiences together from different countries, and they help to develop and organize, amongst other, this event. And now it's my great joy and pleasure to hand over to our co-chair. It's Linda Cliffan.
Good morning, everyone. I'm Linda, and I've lived with cough for more than 20 years. I'm a member of the Cough Patient Advisory Group, and every time I cough, I think, now, what caused that? People around me always offered their advice and opinion on my cough. So I'm really pleased to be here today to hear from the experts, and so delighted to see people from all over the world joining us. Many people haven't heard of chronic cough, but so many people around the world have it. And that's why this conference is so important, to help us understand cough better, learn how best to manage it, and to hear about treatments and the latest research. As you know, we have a fantastic response to our conference. Over 412 people have registered so far up to this minute, and from over 50 countries. I've already read South Africa, Australia. Oh, look, it's so wonderful to see you all. It's amazing. And it's such an opportunity to engage with each other. So remember, we want this to be an interactive conference. Please say hello in the chat, tell us where you're joining from, which lots of you are doing already, and ask questions. Our speakers obviously can't answer specific questions about personal circumstances, but we really want you to be able to gain the knowledge you need. So please ask questions, don't be shy. You're probably thinking of the question that everyone else wants to ask. If you use social media and Twitter, please do tweet about the event. using the hashtag CoughConference2022. Now, I have great pleasure in handing over to my co-chair, Lorcan, who will introduce today's programme.
Hi, Lorcan, I think you're muted.
Good morning. Thank you, Linda. Lorcan McGarvey is my name, and it's my pleasure to co-chair this cough conference. I'm a chest physician and have been looking after patients with chronic cough for more than 25 years. I'm also a professor of respiratory medicine at Queen's University Belfast, and I've been, I guess, working in the field trying to understand the science and trying to help with the clinical trials that have been ongoing for a number of years in this field. So I'm really pleased to be here with you all today. Linda's already introduced some of the really important aspects of what we're trying to do. We're really very fortunate to have so many expert speakers covering really three broad themes over the course of this morning. We really want to give you, first of all, an overview of chronic cough. And so we've had a break and had an opportunity to think about that session. We move on to where we are currently with managing chronic cough. What's the evidence base for that, and how best can we ensure that clinicians around the world are managing cough in a standardized and organized manner. And then, of course, this is a very exciting time for those of us who are working in the field of cough. It's also an important time, I think, for patients, letting them know that there are really some exciting developments in this field. And we have a session then really on future developments in the field of chronic cough. Crucially, there's an opportunity for all of you to get engaged and involved with the question and answer. So as Linda said, please do use that function, and we'll do our very best to answer questions during the various Q&A sessions. There are no stupid questions. There are only questions that need to be answered. So please feel comfortable about feeding in with your thoughts, your opinions. Please use the various icons, the thumbs up, for example, if you particularly want a question to be answered, and we'll try and flag that one up for our panelists. I want you all to enjoy today. We really do. And I'm going to hand you over now back to my colleague Keld, who'll take you through some of the practical issues and housekeeping for the rest of this morning's conference. Thank you all very much.
Thank you so much, Lorcan. So I am then going to take you through some of the house rules or the housekeeping rules for today. So we are conducting what we call a webinar style event. So attendees can only see the speakers and chairs and hosts. So participants are muted, but they can participate in the chats. And in particular, if you want the experts to respond, or maybe some of the experts' patients as well, to respond to your questions, then use the Q&A function at the bottom. And I saw there was also a comment about this in the chat. This is a recorded event, so the talks will be made available on the ELF website and the Neurocough website after the event, so you and others can freely access them. And you might also want to share the links with your friends and colleagues from around the world, so a wider community can engage in this. The way that the Q&A works is that you write your question in the Q&A board, and then we'll try to answer as many as we can in the time that we have. Those that are not answered, we will try to answer after the event, and then put the answers to the questions, both the questions and the answer, on our website after the event. So we have had previous patient conferences with up to 500 questions. So feel free to to ask a question, and we'll see how far we can get with the answers today. So now I'm very pleased to hand you over to Peter, who is also co-chairing the event.
Hi everyone, I'm happy to be here. I am a respiratory physician from Frankfurt, from Germany. I'm working in Frankfurt in a hospital-based office. It is a group practice, and we are treating many patients with chronic cough, and we are a little bit specialized, and we published a paper on German patients with chronic cough. So I get patients from the whole country. I think I am absolutely attracted about the number of people who are watching this event. Here you can see a map. I think most all the world we have participants. I never thought before that we will have so many people from so many countries, from all continents. I'm happy to see this, and I want to hand over to Linda. She will open the first session now. Thank you very much.
Hello again, everyone. So the first session today is an overview of chronic cough. And first of all, we're going to show a short video of patients talking about what it's like for them to have chronic cough. And I know lots of people will identify with this. So here we go.
Well, it started when I was singing. I loved to sing, and I used to be humming and singing all the time. And that's when it started. I would sing, and all of a sudden everything would go and I couldn't go on.
I have a tickle in one's throat, and then it gets higher and higher, and it's a problem for me to breathe.
It's really just a spontaneous urge to cough. That seems to be the predominant thing for me. Occasionally I have the sense that something blocking my back of my throat, or there's some sort of slight irritation.
Ja, die Problematik ist dabei, dass man plötzlich husten muss. Es hat angefangen mit Hustenanfällen beim Telefonieren, beim Autofahren. Da habe ich eventuell gedacht, na, es ist die Klimaanlage. War nicht allergisch, bin ich auch nicht.
My mother had a cough, and sadly my son has a cough. I have 10 grandchildren, so I dread the thought that one of them might develop this persistent cough. Well, it has been thought that possibly my cough was genetic, but I don't think anything has ever really come of that. But it certainly does seem to be a feature in my family.
It gives me a sore throat. I sometimes get a pain across my ribs, which I'm sure is due to just constant coughing.
Physically, sometimes I have a very violent coughing fit, and I can cough myself physically off my feet. And then sometimes there's a sense that you're straining your stomach muscles when you cough. It's a really tight grip on you, and occasionally a desire to vomit. You know, if there's a lot of mucus, it can make me physically want to be sick.
And suddenly it explodes. And when I say it explodes, it's overwhelming. It takes over. I'm coughing up mucus, my nose is running, my eyes are running, my ears feel choked up, my chest feels tight and painful. For perhaps 2 or 3 minutes, I'm unable to do anything because it is all-consuming.
It's a sort of a sense of exhaustion sometimes, you know, that coughing is a bit draining.
Because I choke, and I even vomit, and all the pressure goes to my head, and things start turning around. And what I'm afraid of most of the time is that pressure increasing in my head when I cough, and I'm afraid to have a stroke.
I have had times when I felt really depressed and cried, really, because especially on a night when you're coughing and everyone else is asleep, or there's nothing you can do, nothing seems to stop it.
Going on to a social thing, you're not sure if you're going to cough. And I'm not embarrassed around friends or people I know, because I'm very upfront about telling people I've got a cough. And if I do think I'm going to cough in a very, in a social occasion, I'll just take myself into a corner and have a private cough. So
ja, man schämt sich, man traut sich nicht ins Kino zu gehen oder Theater schon gar nicht, weil das wäre ja verheerend. Ja, und das Ganze, das macht schon ein bisschen traurig. Man weiß nicht, was das ist. Kollegen fragen, was hast du denn? Bist du erkältet? Was ist denn los mit dir? Ja, und das im Sommer, im Winter, egal von Wetter. Während der Arbeitszeit war es auch nicht sehr prickelnd, denn die Kollegen, die fragen auch, was ist denn los? Willst du uns anstecken oder ja, warum bleibst du denn nicht zu Hause?
And I suppose COVID, during the sort of height of COVID, when people looked at you aghast as if you were carrying disease.
I'd rather excuse myself and say I'm not contagious than prevent myself from going to places and seeing things.
Socialising I found very difficult. You're constantly wondering, am I going to cough? Will I cough now? So it's not very easy to put yourself in situations where you don't know people and they don't know you. It's just a constant thing that you kind of carry it with you, really.
It can be triggered by almost anything, but most particularly by strong smells, perfumes, chemicals, dust, a change in environment, changing from one warm atmosphere into a cold or vice versa. But often it can be triggered by nothing that I can possibly see.
The triggers of my cough are so numerous now, really. I can't pin them down, and often I can just start coughing when there doesn't appear to be any trigger at all.
And it can be provoked by very numerous things like talking, being on the phone, bending, laughing, drinking.
Temperature changes, very specifically going from cold to hot, or blasts of air. And also when I'm very focused, I don't seem to cough. When I'm very, very focused, it seems to be when I stop and I change my physical position and then I cough. Cooking is a problem because steam from cooking, opening an oven door where steam, hot air and steam blasts out. So smoke and fumes make me cough, and some foods, particularly dried food.
Ist ja immer in der Angst, wann kommt der Husten. Das kommt immer unerwartet, also hat man immer eine kleine Flasche mit einem Getränk dabei. Oft hatte ich auch Kamillentee dabei, weil da hatte ich das Gefühl, dass Kamillentee hilft. Ja, dann immer wieder Wasser im Auto, in der Handtasche und ja.
I mean, I tend to take cough sweets with me because I do find they moisten my mouth more. I don't find drinking water helps with me. I do try and relax as well if I do go to a show or a cinema. I can get myself in a sort of state where I'm just relaxed, and that does help.
A specialist that I saw at the beginning said I should take some Tic Tacs, which are a strong mint. So sometimes I have a nice whiskey to calm the stuff.
If I have an attack, a cough attack, I will breathe slow, slow and slow, and then it's okay. Sometimes it helps when I feel this, that it will come, to drink something. Fluid is okay. And for the night, I will have cough syrup. And I think it's more for the brain. If I had this, then it's okay for me for the complete night. And I do not have this cough for the complete night.
So them really listening and them really understanding is the key thing with family and friends, and them not showing frustration and irritation when you start coughing. It's not always helpful for people to be saying to you know, do this or do that, because I've lived with it long enough to know what probably I should be doing, if that's going to make any difference, which doesn't normally.
I have other friends who are just constantly asking me, have you still got that cough? As if there's going to be some sort of time when I don't have it. And no matter how many times you say chronic cough and explain, it seems if you don't, because you don't sometimes see some friends for a while and they still think, oh, you've got that cough. And then it becomes part of the conversation, which I don't really want. I think the best way you can help people with a cough is understand it, accept it, and just, unless they want to talk about it, I just wouldn't bring it up, really.
Dear participants, now it gives me a great pleasure to introduce our first speaker, Professor Stuart Marzoni, who will be explaining why we cough. Professor Mazzone is a professor of neuroscience at the University of Melbourne, Australia, not just around the corner, and is a leading authority on the neurobiology of cough. Yes, I hand over to you, Stuart. Please.
Thank you very much. And let me just start by thanking the organisers, the ELF and the Neurocough Consortium in general. What a wonderful symposium that we have planned here today. This is an outstanding idea, and I really congratulate the organisers for putting this together. It's wonderful to be joining you all the way from Australia, and it's great to see so many people from so many different corners of the world. So welcome. What I hope to do today is to talk to you a little bit about why we cough, and hopefully in doing so, convey three kind of key messages by the end of my talk. And the first message that I'd like to get across is that cough itself is actually an essential protective mechanism that we have as humans. So we often think of this as being a good cough, and I'll take you through some of the reasons why we have cough and why we need it to be in place. But of course, as we've heard in the videos that have just been, cough can become a problem for many people, and particularly when it's a chronic cough and it's a very difficult cough to treat. And so this is not an uncommon condition. That's the first point to make. But it's not the same for all patients. The causes are not the same, and the disease itself is not the same. There are some common features, and hopefully again by the end of my talk you'll understand a little bit more about those common features. And then the final point that I'll make and reiterate at the end is that we are making some progress towards effective treatments. So in order to understand why we cough, we need to understand a little bit about breathing and swallowing in general. And of course, I think we all know that when we breathe, we're essentially inhaling air from the environment around us, often through the nose, sometimes through the mouth, but with the goal of getting this air into the respiratory passages, ultimately into the lung, where we need oxygen to be delivered for oxygen exchange to occur. By contrast, when we eat something like this hamburger, then of course, we want that hamburger to go into the esophagus, into the digestive system, and ultimately into the stomach for digestion and absorption. What you can see from these images that you're looking at on the screen is that some of the anatomy that the air and the food pass through is shared. What you can also see is that there's a very close arrangement of the respiratory system with the digestive system. And this is actually important because if we're inhaling air that the quality is perhaps not as good as it should be, there may be smoke or other chemicals in the air, then that can enter the respiratory system along with the oxygen that we need and cause inflammation and damage. And if we can't swallow effectively, or if there's a problem with our swallowing, then the hamburger may well end up in the respiratory system as well. Or there can be reflux of foodstuffs from the stomach back into the respiratory system. And this is dangerous because it can cause obstruction or irritation and inflammation. And so this is why we have a cough reflex as humans. It's a protective response so that if there is something nasty in the air that we're breathing in, or if we don't swallow correctly and there's aspiration of foodstuffs into the respiratory system, then we've got a means to rapidly clear the airways in order to ensure that our breathing, the primary function of our respiratory system, is maintained. Of course, if it's not, then it can have dire consequences for our health and in fact even be fatal. So this is what we think of as being a good cough. So good cough triggers are things like aspiration of food or liquids or the gastric contents being refluxed and entering into the respiratory system. There can be inhalation of airborne particles or chemicals that are potentially dangerous. And even in some acute diseases, the accumulation of mucus, which needs to be cleared in order to ensure that the respiratory system is not obstructed. So all of these are normal triggers for the cough reflex, and they're there to prevent damage or potentially obstruction to breathing. So how is it that we cough? Well, we cough because those sorts of triggers activate the nervous system. And the parts of the respiratory system that we've been talking about, the larynx and the trachea, are heavily innervated by nerve fibers. These nerve fibers all arise from a nerve called the vagus nerve. But essentially, many of these nerve fibers are sensitive to different types of stimuli. In fact, many noxious or potentially damaging stimuli. So if that hamburger or some chemical in the air is inhaled, and it enters into the respiratory system, these nerve fibers are positioned there to detect it. And when they detect it, they send information back to the brain, and this information is used to trigger coughing. And this is what a piece of your respiratory system actually looks like. So this is a real human airway. It's been processed so that we can see the nerve fibers. So all of these green squiggly lines are in fact nerve fibers in the airway wall that are sitting there positioned perfectly to detect the sorts of stimuli that we've been talking about. So if a piece of food or a dangerous chemical lands on this airway wall, those nerve fibers become excited and that information is sent to the brain to trigger coughing. Now, cough biology is very, very complex, and we're not going to go over this slide in any detail. But what I wanted to do is to give you a sense of how it all works. It involves the nervous system, as we've mentioned, which therefore means it involves the brain and the brain stem as well. But effectively, those nerve fibers that are in your respiratory system are equipped with a range of stimulus detectors. These are proteins that are responsive to the sorts of stimuli that the respiratory system would consider to be irritating. When there is a stimulus in the respiratory system, these nerve fibers detect it and send information firstly into the brainstem, the lower part of the brain. And this information then can be used to trigger a reflex cough response. Now, reflexes are very, very quick and very, very efficient. And this is a way of rapidly clearing the airways of that potential irritant that initiated the response. But then in addition to this, information is also sent into the higher brain. And it's within the higher brain that we get a number of other components of cough occurring. And we heard in the videos that many people experience this itchy or irritating sensation in the respiratory system that accompanies their cough. Often we call this the urge to cough. This can be used to trigger voluntary coughing or throat clearing, maneuvers that are trying to relieve this sensation, but often don't work terribly well in patients with chronic cough. This information can also be used to activate pathways to try and suppress your cough. If you're sitting in a movie or in the theatre and you're trying desperately not to cough, it's the higher brain that is performing this function. But really, really importantly, of course, the higher brain is responsible for determining how you feel about your cough. So whether or not it's an unpleasant sensation, it makes you feel anxious, depressed, unsettled, those sorts of things are processed in the higher brain. So with chronic cough, of course, it's no longer a protective response. And that's the problem. It's typically cough that lasts longer than 8 weeks, but for many people, it can persist for years, even decades of their life. There may be periods where it's not so bad and other periods where it's particularly bad, but cough is often present in these people for very, very long periods of time. Importantly, it's not a productive cough. It's a very dry, hacking cough, and these features reflect the fact that it's no longer a protective response. There is often a persistent sense of irritation in the respiratory system, this persistent urge to cough, and there can be these other physical and cognitive manifestations, as we've heard. Some people have urinary incontinence, there can be rib fractures and other physical manifestations. Anxiety and depression is very, very common in patients with persistent cough. Now, why is cough so difficult to treat? Really, one of the reasons is that we need to be able to stop the unwanted coughing without blocking or inhibiting the good cough that we absolutely need for survival. And this is really a challenge. How is it that you reverse the excessive cough that patients have with chronic cough, but leave in place their normal protective cough? Another reason it's quite challenging, it has been quite challenging to treat, is because not everybody's cough is the same. For some people, their cough is associated with a disease like asthma or gastric reflux, and they respond relatively well to therapies that target these diseases. But for others with the same diseases, they can often be unresponsive to therapeutic intervention. Their cough persists despite the disease being treated relatively well. We refer to this as being refractory chronic cough because patients are refractory to the intervention that's being used to treat the disease. And then we have patients as well who simply we can't identify a disease as causing their cough. These people have a condition we call unexplained chronic cough. And so we need a deeper understanding of the mechanisms that are involved in these processes in order to design treatments that work for you. In general, though, what we find is most of these patients, despite the cause, have a common feature, and that is cough hypersensitivity. Effectively, this means that their nervous system has an increased responsiveness to stimuli. We heard in the video many people talking about that persistent sense of irritation in the airways, the itch, the tickle. These are a characteristic of a hypersensitive syndrome. But also the types of triggers that cause your cough. These are often triggers that don't normally cause cough in people without cough hypersensitivity. Smells and perfumes, different types of chemicals. So again, this is all features of an increased sensitivity of the nervous system. And what we think is happening is that there are both processes out in the respiratory system, inflammatory processes, that are making your cough nerves more sensitive to triggers. But these processes are different in different people. We also now know that there are changes in the way in which the brain handles or manages the information that's coming from your cough sensory nerves. But again, these mechanisms are not the same for all people. Effectively, what's happening is the nervous system is acting like an amplifier, and it's taking very, very benign stimuli and turning them into something that the nervous system sees as being noxious or potentially damaging. And so finding ways to dial down this amplifier to reduce the level of amplification is ultimately what we need to treat chronic cough. Now, in my last two slides, I'll just give you a hint of some of what's to come later in the symposium. And that is that we've identified one chemical mediator that we think is very important for this amplification of sensory information. And this mediator is known as ATP. ATP stands for adenosine triphosphate, and it's a chemical that's normally present in all of your cells, very important for energy production. But in injured or damaged cells, like in the respiratory system, ATP can be released and it can act on nerve fibers. And it does so via these particular receptors known as the P2X3 receptors. When ATP binds to the P2X3 receptors, the nerve fires more and becomes more sensitive. Now, fortunately, by knowing this, we've been able to develop drugs that target these P2X3 receptors. These are known as P2X3 blockers that prevent ATP from binding, effectively reducing the activation and sensitization of the nerves, reducing the nerves from firing and improving chronic cough. And these drugs are now in advanced clinical trial, and we hope to see them on the market soon for patients such as yourselves. So that's all I wanted to talk about today. Hopefully it's a good overview of the mechanisms that are involved in good cough, why cough can be a problem for some people and the processes that we think are at play, and some relief, I suppose, that we are actually making progress towards treatments in the future. Thank you very much.
Stuart, thank you. That was just so interesting and informative. And I know for one, I will be watching your presentation several times over the next few days. Sorry, just a few technical issues there. So yes, thank you. That was so interesting and informative. And I, for one, will be watching your presentation several times because there was so much information to take in, but a really positive slant on what we're all trying to improve upon. So the next presentation is going to be from Peter, my co-host, who is going to talk about whether cough is a symptom or a disease of its own. Now, a pre-recorded version of this is available in German on the link if you want to do that. So over to you, Peter.
Thank you very much. I try to share my okay, I hope you can see now my presentation. Yeah, I start. You can hear me. Chronic cough, is it a symptom or a disease of its own? Here I show you the very well-known classification of cough and the causes of cough. Acute cough, duration less than 3 weeks, subacute 3 to 8 weeks, and chronic cough, what you can see on the right-hand side. This is our issue today, and you can see here many diagnoses, many illnesses causing cough. And another type of classification is whether the cause of cough is evident clinically or not evident. I give you an example. If you have a common cold, a flu, and you will start to cough, acute, it is very evident that the cough is due to the common cold. On the other hand, if you perform a few investigations, chest X-ray, lung function, and you take the history, of the patient and the physical exam, you will find a number of diseases which can cause a cough. So the diagnosis is evident. The cough is a symptom of a lung cancer, for example. On the other hand, there are cases where you are not able to identify so simply the cause of the cough and the underlying disease. It was already said by Stuart, then we are speaking about chronic refractory cough or chronic unexplained cough. The problem is with the chronic unexplained cough that we teach still today on the university medical students that cough is just a symptom like fever or pain. And you, as a doctor, must find the cause for the disease to help the patient. If you cannot find any cause, then you are a bad doctor. And in fact, in a scientific trial 40 years ago, American colleagues did find the cause for chronic cough in 100% of the investigated patients. If you can see the abstract of this paper, a specific diagnosis was made in all 49 patients investigated. I and other in the late 80s repeated these observations, and we observed in Germany 329 patients. Lorcan published a paper from Northern Ireland, from Brazil was published papers, the US as well, other papers. I was really ashamed that I was not able to see the cause, the disease, what is causing the cough in as many as 20% of all those patients we investigated very exactly. We did all the available tests. Many had bronchoscopy as well. Nonetheless, 20%, no idea why they are coughing. And it is so, if you take the history, you take the physical exam, careful history naturally, you take a chest x-ray and the lung function test. This is common in all national and international guidelines as a standard of diagnosis of chronic cough. And if you have no results, all unremarkable, then you have no diagnosis and you have the problem. The chronic cough as a symptom, there are libraries full with publications and books on diseases causing chronic cough. I show here just a few. It's completely impossible to show all. But as we heard already, you can have chronic cough not only as a symptom, but as a disease. You can look for triggers like asthma, which you are not able to diagnose immediately because the patient is coming, for example, with a normal lung function. Reflux can cause a trigger cough. Upper airway diseases like rhinosinusitis, laryngeal sensitivity, and so on. And there is also a cause can be taking AC inhibitors. These are the most popular first-line antihypertensive drugs. These are the pril drugs, ramipril, enalapril, clinalapril, and so on. If you are taking such a drug and you stop taking it, in many cases, the cough will go away. But if the cough doesn't go away, you treat the asthma, the reflux, and so on, and the cough remains, then it is a chronic refractory cough. And in many cases, you will not find even a common trigger, and then this is a chronic, unexplained, or idiopathic cough. Now, the question, for example, for the reflux cough, if reflux causes cough, as Stuart could show it, how effective is the reflux treatment against the cough? And this question was looked for by American cough panel, chest cough panel panelists, and they looked the literature what was published. Patients were treated against reflux, or they were treated with a placebo. Placebo is a pill without active drug. The active drug was in the most trials a PPI, a proton pump inhibitor. These are the prazole drugs, omeprazole, lansoprazole, pantoprazole. They treated the patient, and whether the patient got placebo or PPI, the result was the same. At least in average, you will not have in average a beneficial effect from PPI, which is more prominent than the effect of placebo. Naturally, a minority of the patient will have very good relief, not only the heartburn, but also the cough. But in average, it is not the case. I participated in 2 of these 14 trials as a center. The conclusion is that most of those trial patients with reflux and heartburn suffered from chronic refractory cough. I was asked to speak about Hypochlor Heteria. This is little stomach acid as opposed to reflux. Little stomach acid can be the consequence of a chronic infection with Helicobacter pylori, which is decades-long infection. It starts in the childhood, and you get chronic gastritis and mucosal thinning, and then the mucosa will not produce enough acid. Or it can be the same, it is a changing in the mucosa due to an autoimmune disease. It is well known that if acid and enzyme like pepsin production are absent, you will get, for example, trouble with the vitamin B12 resorption, and you get anemia. This is called pernicious anemia. Pernicious anemia was 100 years ago non-treatable disease because the cause was not known. Now it is a clearly treatable disease. I don't know what will happen in 100 years with chronic unexplained cough. The Hypochlor Heteria are causing also gastric cancer development, but it does not cause cough. If so, why are these and other patients coughing? They don't cough from reflux, they don't cough from lung cancer, they don't cough due to asthma. Why are they coughing? And now, 9 years ago, Alyn, the next speaker, established a real paradigm change, sorry for the German, paradigm change. Chronic cough hypersensitivity syndrome was established. Stuart already explained you what is cough hypersensitivity. I explained it in my way. If in this room is burning and you have a very dense fume and I inhale it, I breathe it, I will start to cough. If in a big room, people are sitting together and one is starting to smoke, and you are 15 meters away in this big room, but you can still feel the smoke and you start to cough, other will not do that, then you are hypersensitive. This is the cough hypersensitivity syndrome. And last, a few slides to a very actual problem, the SARS-CoV-19 infection, because it causes cough as well. Shortly, you have a biphasic course of the disease. It starts a viral phase lasting 10 to 14 days. And if is no resolution, a patient must be submitted to the hospital, and they get a hyperinflammatory phase, cytokine storm, organ damage, which can end with resolution, but also death, or you get a long COVID. You have symptoms over many months after the disease. Cough was the second or third most frequent symptom in the viral phase. I will show you. And in long COVID, it is not as prominent. In long COVID, you have to ask the patient, are you coughing? And the patient will say in probably 30% of the cases, yes, I do. In contrast, in acute viral phase, many patients are coming and saying, doctor, my cough is terrible. It was an early slide from the American Thoracic Society. And here you can see at the beginning of the pandemic that cough was as frequent as up to 80% of presenting patients. This was the case at the same time in Germany as well. Cough at presentation, there were hospitalized patient was as usual as 70% of the cases. If you ask the patient 6 weeks later, only 33%. And that this is not a German phenomenon. This is a Norwegian paper, and you can see dry cough up to 70% and a few percent productive cough at the presentation in the acute phase, and in the post-COVID phase, only dry cough altogether productive and non-productive up to 10% of all cases. So COVID is a special case. COVID-19 is causing both acute cough like a flu, influenza infection, and also long-lasting chronic cough. Thank you for your attention.
Thank you. Thank you, Peter. That was very interesting, a very comprehensive interview, a very comprehensive overview of all the things that affect you. And, you know, doctors and physicians worldwide have got a huge job ahead of them to help us all in this field. Our next talk is from Professor Alyn Morice, and he's going to explain some of the potential consequences of chronic cough, which I know will be interesting to everyone. Professor Morice is head of respiratory medicine at the Centre for Cardiovascular and Metabolic Research at Hull York Medical School in the UK. He also leads the Hull Cough Clinic. So looking forward to hearing from you, Alyn.
Hello, everybody. Yes, I'm perhaps the oldest participant in the conference. My first paper on cough was in 1987, and I know some of you have probably had a cough as long as that as well. I'll just try and share my screen. So I'm calling this the cost of cough because it's an enormous burden on patients. And what I'm going to show you, I work with a lot of the companies that are developing these new drugs, which are very exciting in this field. We've got 4 or 5 drugs coming through. But first of all, I'd like to just play a quick video of one of my patients.
So in the last 17 years, I've had a chronic cough, which has completely taken over my life. It has meant that as a head teacher of a large comprehensive school, I was unable to function in my role because I couldn't address a meeting, speak to students, speak to parents without fits of coughing that could last perhaps up to 10 minutes at a time, and perhaps 6 or 7 times a day. Along with the cough, I had other effects, which the cough was so severe that I tore my bladder, which when you're coughing is a big problem because you become incontinent, and it became so severe that at times I didn't want to leave the house. I've had 2 bladder repairs and been told each time that the repair is probably not going to last because of the force of the coughing. I had a hysterectomy because I prolapsed my wound coughing, and I'm currently seeing my GP about bowel problems because occasionally during bouts of coughing I lose control of my bowels as well as my bladder. I find it very difficult to go out in public. The number of times I've left a trolley in a supermarket because I've bent over near a freezer to pick something out, and the cold air has hit me and I've started convulsively coughing, and everybody around looks so concerned that I've just left the trolley and left the supermarket because I can't bear the embarrassment. I can't think of an aspect of my life that this cough hasn't taken over. The first thing I do when I meet anybody new is explain to them that the cough isn't contagious, because I do worry that people think that I've got some dreadful disease. The self-esteem thing of that is very, very difficult. That when you're getting ready to go out, it's then in your mind whether people are going to treat you as though you are some sort of social outcast. And usually I feel silly getting upset now, but it does upset me because I do feel that the last 20 years have in some ways been lost, because all I think about at any time is how the cough is going to affect whatever I do.
So a very powerful testimony there from my patient. In fact, we made her better. So there is hope, even if you've had it for 20, 30, perhaps 40 years. My record is 66 years, and I made her better. So there are drugs and treatments which are available now, but these new drugs will be coming. The problem, I think, for most patients with cough is that when you go and see a doctor or a nurse, they don't really understand the cough. The cough is, as Stuart has said, hypersensitivity of the nerves, and they're not trained or taught about this. So they don't see the cough as a disease. They look for the cause of the disease, look for the cause of the cough, rather than actually accept chronic cough as the disease. So you'll go along and see the doctor, and this is an ancient Indian tale of 6 blind men who go along and feel an elephant, and each one has a different opinion about what's wrong. So here at the bottom right here, bottom left rather, there's the guy feeling the trunk. He's the EMT surgeon, and he sees it as a snake. The guy here feeling the side, he thinks it's a wall. And the chap at the end here thinks it's a rope, because he's got the tail to feel. Each person that you go and see looks at it from their own speciality point of view, and they don't see the whole elephant. The whole elephant is this disease of chronic cough. So you will get different opinions from different doctors because they do not appreciate that this is a disease, chronic cough caused by hypersensitivity of the nerves, the vagus nerve, as Stuart pointed out. So I've been asked to talk about the 3 questions that the advisory group sent me. Could cough cause physical harm, psychological and social harm? What about the tests and unnecessary investigations that doctors put you through? Well, let's do the psychological and social harm first. Well, the problem is, as I've said, that the doctor has been trained to look for the disease which is causing the cough, when in fact the chronic cough is actually the disease. And it's quite easy to diagnose it, actually, because it has a very common set of features. Not everybody exhibits all of the features. Other people exhibit different features, but there is a unique history, as it's called, of chronic cough. And I think it's the ignorance of the medical profession and the nurses who try and diagnose you as asthma, or try and diagnose you as a pulmonary fibrosis or other diseases which they've been taught about, but nobody has taught them about chronic cough. And this is the great thing that me and my colleagues are trying to do, is to get people, the doctors, to be aware of chronic cough as a disease. Can it cause harm? Well, as Stuart mentioned, reflux is a very common, in fact, in my opinion, by far the commonest cause of cough, but it's not acid reflux. The doctors are taught about acid reflux, whereas in fact the reflux is not acid, and it comes up and irritates the lining of the lung or the voice box, and then that, as Stuart has said, releases substances which irritate the nerves. So this reflux can actually go into the lung, and it can cause bronchiectasis or bronchitis. So in some patients, you get the phlegm production. Other patients, it's just a dry cough because it's only the nerves that are being irritated. But in quite a few patients, they will cough up mucus, and that's because the airway lining has been irritated by this aspiration of the non-acid reflux. That's why the drugs that are given for reflux, PPIs, Peter mentioned, PPIs don't treat reflux. They just block the acid. So it's non-acid reflux which is causing this, not acid reflux. And the doctors give the wrong drugs for acid reflux, when in fact it's a non-acid phenomenon. So my last slide is, what can you do and what shouldn't you do? Well, it's very simple, really. You need a chest x-ray if you've had a chronic cough, because sometimes there are things wrong with the lung that the doctor can see on the x-ray. I've developed this questionnaire called HARK, and you can get it on that website, issc.info. It's in 40 different languages, and it's 14 questions, and they are targeted at trying to get the characteristic symptoms of this non-acid reflux cough. So patients will often cough when they get out of bed in the morning, for example, and that's a reflex opening of the valve at the top of the stomach to allow the gas that's been trapped in the stomach overnight to escape. Talking and laughing stretch the valve, and that causes the coughing. So it's all very easily explicable if you understand the physiology behind it. But unfortunately, the doctors are not trained to understand this. So go on that website, do the HARK questionnaire. A score of about 14 tells you that you've got a airway reflux. It's not acid reflux, it's an airway reflux, landing on your voice box or going into your lungs or going up your nose even, giving the nasal symptoms that people get. And you should also make sure that you have a blood count, because some patients, when they inhale this stuff, it causes an allergic type reaction. It's not a proper allergy, it's an allergic type reaction which has the same cells involved, and they respond to some of the anti-asthma treatments, but not as well as ordinary asthma. So very simple thing to do when you see a doctor. Make sure you have a chest x-ray. The heart questionnaire should be shown to them, and the high score on the heart questionnaire tells you that it's this non-acid airway reflux that you're getting, and make sure that you haven't got the asthma type of reaction in the lung, and that's easily obtained from a blood count. So you don't need all the CT scans, you don't need all of the other investigations that the doctors do. They try and make you wheeze or whatever. It's usually not asthma. That's the problem, is that it is not the conventional diseases that the doctors have been taught about. It is the disease of chronic cough. And I think that's it. Yeah.
Thank you very much, Alyn. It was a very interesting general view, and as you could see, cough is really a problem, and cough is a very severe disease. I think we should go to the question and answers, and I want to ask first Lorcan to answer the questions on IPF, idiopathic pulmonary fibrosis. Are you here, Lorcan? Yes.
Yes, I am, Peter. I've been following the questions now over the last half hour or so, and first of all, great to see so many. I think one of the themes that's come out, we've had a few patients who have been previously diagnosed with other lung conditions. Pulmonary fibrosis is certainly one that's appeared on the question and answer section. Yes, cough is indeed sometimes the most prominent and most disabling symptom in IPF. At the moment, there are really no effective treatments, and indeed exactly why patients with IPF cough isn't clear. It is thought that there is some link between inflammation and the nerves that Stuart was telling us about. We call this neuroinflammation, but we don't have any very good treatments to control that at the moment. Unfortunately, some of the therapies that are being developed, for example, these drugs that block ATP, these so-called P2X3 receptors, in one small trial, they didn't appear to be particularly effective, but I think much more work needs to be done in that area. I would focus more now on what is being offered, and unfortunately for some patients with IPF cough, the use of morphine-based medicines and opiate-based medicines are really the only effective treatment. And I think this highlights just the problem that our patients with IPF face. And this really represents an area that needs a lot of attention and a lot more understanding and hopefully new treatments. So it's a real problem.
Thank you, Lorcan. I can ask the next question. I feel like my cough starts dry, then it progresses to an irritation in nasal airways and becomes more moist, more wet. Who want to answer this question?
Will I have a go, Peter? Yeah, you see, if you're believing me that there is this non-acid reflux, it can go up your nose because it's mainly a gas or a mist, you see. So it irritates the nose and gives you the nasal symptoms. A lot of people get sneezing with it. And it lands on your voice box and it causes the voice problems that a lot of people suffer from. And you can, a lot of patients actually taste it. They get a metallic taste in the mouth, or it tastes like blood, and that's the deposition of these particles in the airways. But the key is that when these particles hit the voice box or wherever, it irritates the nerves and gives rise to a super sensitive cough reflex. So people have been saying that they get set off by a change in temperature, strong smells, bleaches, perfumes. That's because the nerves are super sensitive here. And it's like having a burn on the skin. You blow on it and it hurts. The same is happening in your throat. The throat nerves are super sensitive. And that's why you get this sensitivity to outside things, because of the hypersensitivity of cough reflex.
Thank you, Alyn. I think the next question.
If I could just jump in, I wanted to try and batch a number of questions, linking in again with the IPF question. I see some patients with a diagnosis of sarcoidosis, other patients with a diagnosis of bronchiectasis, and treatments for those conditions don't seem to have been particularly effective. It's just worth remembering that sometimes physicians forget to investigate more common causes associated with cough. And Alyn, of course, told us that in his lecture where he described about the men in the room feeling the different parts of the elephant. And it's worth remembering that conditions like asthma are common and that they should be properly investigated and evaluated. You know, that reflux, again, a common cause, is properly investigated and evaluated and optimally treated. And sometimes when a patient has sarcoid or bronchiectasis, everybody thinks that the cough is due just to that condition. So it's really important that these patients are more completely evaluated. There were also some questions around COVID and cough, and I think this has caused great distress for our cough patients. We heard this from some of the patient testimonies around the social embarrassment, the sense that cough it represents them as being, or identifies them as being contagious. The good news is that post-COVID syndromes do not seem to be associated with very troublesome cough syndromes. So I think we can distinguish chronic cough and post-COVID pretty clearly. I think the issues around COVID, thankfully worldwide, are receding to some degree, but this does not take away from the social embarrassment of coughing in public. And I just hope that our progress in developing new treatments will really help us for those patients.
May I raise the next, probably the last question? Why do we think gabapentin doesn't work in chronic cough? Who want to answer the question?
Well, I'm just going to jump in there, Peter. I mean, I think this session is really more around the clinical aspects of chronic cough. There might be an opportunity to cover that in the next session. Just I'm aware we're getting close to time, but perhaps Alyn, you might want to say something about gabapentin.
Yeah, there are studies showing that gabapentin does help, but it's a very short-term thing. I've not had much success with gabapentin. I try and concentrate on trying to stop people refluxing, and you can have, there's a very common antibiotic called azithromycin, which works on the gullet as well. And I've got great success with that in some people. So it's about understanding how the disease is actually produced that leads you to the correct treatments. So don't treat acid reflux because it isn't acid that's causing it. It's actually the stuff, the gas or mist that's coming up and irritating the nerves up here. So gabapentin is supposed to work on the nerves, but in my experience, we don't have very much success with gabapentin or the other drug, which is called pregabalin. Some people do respond, but it's not as common as is made out in the literature.
Thank you. Probably the last question we can still answer. I will do it myself because this is very typical. Mitchell asked that the chronic cough starts with an infection, with a viral infection, with flu, and then the flu is going away, but the cough is remaining. I think we don't have a real explanation for this. We can say in general that this infection did sensitize the cough receptors and the cough reflex, and later on the cough is persisting. It is not as unusual because we have also a starting infection for asthma, for example. 30, 35 years old people never had asthma, and then they get an infection. The infection will be treated, and the infect goes away, and the asthma remains. I thank you. I think we can later on answer some questions, and I give over to Linda. Linda, please.
Okay, thank you, everyone. Well, that's the end of the first session.